I'll try to be, normally in the beginning, I would never finish my introduction. And now I hope to come to the conclusion. But of course, in all these kinds of research, there's not really a beginning and an ending, but I'll try to do so. So my research is about multilingual communication in the emergency department. Can I maybe have the microphone? I found it easier to look there than here. Thank you. So what I'm going to say is not new in emergency departments worldwide. There's a lot of migrant patients that go there because often it's the first place where they go, be it in Australia or the Kingdom of Belgium. And the very fact of going to the emergency department is already has an effect on your cognition, you know, lack of sleep, you know, and it's stressful for everybody who's there, actually, whether they realize it or not. Often in literature, when it comes to language barriers, it is called, the articles end with "we need medical interpreting," which is true, but often they're not used both in literature and in reality, even when they're present on site in a hospital. And what is also known is that as such in the emergency department, James, I wanted to say James Cook, but it's James French. James said as well, there's a lot of errors in the emergency department because as the colleagues here in Australia and in Hong Kong have been documenting already, it's mainly oral and there's a lot of stress and things often go, be it noticed or unnoticed, are wrong. Okay. So on top of that, there's time pressure, and I think the cognitive load is important because when there's a cognitive load, there is a lot of things you have to do as a clinician, multitasking. There's tiredness for the patients, whoever joins them, emotions. This has all an impact on the cognitive bandwidth and the way we reason and the things we do. And emotion plays an important part in how we do things, even when we do not realize it. Anyway, it has been said before, but I looked for code in Google and I found this one. But I think you said it as well. I think we know that there are problems in communication or that can be challenging when there is language barriers. So this research did not want to prove that. But what I learned is that very often there's a big difference between the way people perceive their communication and the actual communication. I think that's not new too. So this research just wanted to kind of, I'm trying to scroll here. Kind of, it's actually in my mind, when you see the work of Diana's leading colleagues on emergency department care, in my mind, this is, if that was a Russian doll, this is a little puppet that fits in there because they've been working on it. So what this research wants to do actually is just the why and how, describe what happens there. Just, you know, what happens and make the link between communication and the tangible material consequences of it, the clinical reasoning. Because often, you know, it has been talked about before by James and other people, often people don't want it, you know, in the email he got, you know, I'm not interested in it. We got it in the second round, but we proposed a project at K11, and in the jury, there was a surgeon who had been a surgeon for 30 years, he said himself, and he didn't understand why bother, you know. I've been a surgeon for 30 years, I haven't had any problem in communication. So I think it's very human. I mean, people are vulnerable, so we need to help him helping patients. And education, it's the same thing, actually. It's just how humans are in academia as well, you know. So this is, I mean, I'm telling it chronologically, but it all started the other way around. But anyway. So in my PhD in 2013, I started doing it. I ended up in the emergency department. And yeah, I was looking at the literature. And basically, it started kind of lonely. Okay. So the methodology is we did a quantitative survey together with the service, just to have an overview on the perception of the clinicians at triage, on how they perceive communication, and to give some figures to the diversity there was. So the diversity wasn't really, oh, I'm already running ahead of the quantitative survey. But anyhow, I did participant observation, linguistic ethnographic participant observation. Basically, it's what you have been doing as well in Australia and many people have been doing. You go and observe and you document. And linguistic ethnography is actually, that's what I did. It's like a Christmas tree. Actually, I was looking for the word coat hanger yesterday and I couldn't find it in English. And I thought, why don't I just use the word Christmas tree? So, ethnography is a Christmas tree, all right? And it stays all year. And the observation, the lenses to which you look is, so you record consultations and you observe. And in the Christmas tree, you add particular different paradigms that the data ask for to understand them. So in this Christmas tree, we have second language acquisition, because in classroom learning, they have studied how people have strategies to communicate in a second language. Interesting. Interpreting studies, translation, and all. Apparently as well, social psychology, healthcare communication, clinical skills. I downloaded the base guides illegally. And a lot of people that need to be involved for data collection, and we locally need to mobilize them. And for the analysis, it's like Muhammad Ali said in his poem, me, read. And this is what his research is, that was needed for the research as regards the methodology. I also used a live scribe pen. So the pen, you see, that's my hand, okay? And that the pen records audio, but simultaneously as well, you can draw what you see, and it records simultaneously the sounds that were produced as you were drawing. So that was kind of handy, you know, so you got some extra non-verbal or contextual things. Also for interviews, that was handy because, you know, people, it's not linear. Clinicians are seeing different patients at the same time, and then they're smoking the cigarette. You know that patient we saw. I think about this and this and this and this and this and this. Oh, can I interview you about it? So you would go to that page, set across, and you could actually have some kind of accountancy for the scattered information from the ethnographic perspective. Yes, the hospital. This was a hospital in Brussels, officially bilingual. That's another issue, which makes it very sensitive to do research. Because anyway, that's another story. Because language in Belgium is very sensitive, not to me, but to many people it is. It's Belgium's largest ED ward, and it's very, very diverse, both as regards staff and patients. And the people who accompany them, that may be family, they think they're family, but often it's not the case. Very important as well, many undocumented patients. As you see in Europe, you know, the unfortunate suffering of people literally walking, some coming by plane to Brussels and to other places. I think that's important as well, an important contextual fact. This is a quantitative survey, but what is interesting here is that in 40% of the interactions, the clinicians perceived their information as excellent or easy. So that's interesting, because when you look at the interactions, it's not always what you think it is. This research was not there to prove them wrong, because communication is never perfect. So here I'm just going to give you one illustration of one particular case, okay? And it is representative in a way, but in another way it is not representative, because each case is kind of different, okay? But just give you an example. An important thing is that I realized this morning when I had a look at my presentation that I had put the transcripts in there without the transcriptions conventions. If you want to have them, I can send you the work. Okay, so I can use it for publicity. Okay. So actually, what we wanted to do is just visualize what happens, which is already difficult. So this is a case. It's at midnight. Okay. I don't know when the patient got up and her companion. I didn't ask them either. But the clinician in question, the nurse had started at 8 p.m., but the clinician in question had started at 8 a.m. in the morning, and he was still there, okay? I was there in a sense that I felt tiredness as well because I was teaching during the day. So you have this kind of jet lag, this feeling, and it's not about me having a jet lag, but that particular feeling ethnographically is interesting. Everybody's kind of tired, okay? And then you have to make meaning in another language for both of them, okay? And just before, I'm just checking my slides, so yeah, I have to go to the next one. Okay. So this patient had come in the ED after 8 p.m. Okay, this means that in this particular ED there was no triage anymore. Okay, so the nurse had seen the patient, a female patient, and a companion of hers, and we don't know how they. Very important in the ED, you don't know how companions are related to the patients. So they think often that it is family, but often they're other people. But they're thinking that they're family, we talked in the previous presentation, they treat the person as a valid source of history as well. And that can be sometimes problematic in combination with the other challenges that go with triadic interactions. So the candidate diagnosis finally was tuberculosis, but we already had gone in. So we left the room and we came back with masks. And the patient was isolated in the sense was put on a mask as well. So the semantic value of that ritual is important, but they were not able to explain it. Okay. And the doctor had already done his differential he wanted to do a differential diagnosis. He wanted to know whether the patient had tuberculosis or not. So he wanted to know, has she been coughing? Is it with blood, chest pain, these kind of things. So we had started doing these things in French, and the patient and the companion kind of spoke French relatively well. I mean, they could say, bonjour, ça va, oui, no, un peu. So it was there was some kind of joint repertoire, which is kind of important. But then the doctor announced the testing, we'll faire un radio, we're going to do an X-ray scan, and you'll have to spit in a cup. Cracher. And before what happens, she said, so she was thinking you have to send them that she had to go away and do something else. You know, in the cup, things that you do in the cup. So that was confusing, but this was interesting because it made the doctor a bit insecure. Okay, oh, maybe the patient is not understanding me and the companion enough, which leads to diagnostic insecurity, which we know. So this happened before. Okay. So he was kind of, this happened before, so he wanted to explain what does the spit mean, cracher. Okay, 5 minutes, all right. Time goes so fast when you talk. So basically, basically what is important here is that the fact that the interesting thing in this particular case is that both the doctor, the companion, and the patient try to display their understanding and their non-understanding. And this is something that often does not happen. Okay, so in a way, it is they're trying to understand each other, so you see these things. And the doctor uses these kind of non-verbal communication. Often it's not done. When you ask clinicians, do you do that? Yes, we do. But when you look at the data, they don't. They think they do, but they haven't done it. Okay. And so it gets kind of confusing because the doctor is kind of confused by the fact that she does not understand cracher. And she says, cacher is to hide, so there's confusion. And I needed to have the carrot for the donkey in the ED, so I came up with gadgets to communicate. Okay. And they called me Inspector Gadget. Up till recently, I thought that was a French series, actually. Because we would watch it in French. Anyway, so patient is there. I'm not going to get to my conclusion, but anyway, the patient is there. Companion is there. I'm standing like this. The doctor is there. And he says, let's have a look at your tablet to find a way if we can kind of communicate with her in Polish. It's a multilingual history taking course. So you click on it. So it's in French normally. and then you click on it and it reads it loud. A question, it's unidirectional. But the problem is that the doctor wanted to know, he didn't know the system well. So he clicked, thinking, oh, maybe we can have questions in Polish per system. So he clicked on the words tuberculosis in French, and then it read out loud tuberculosis in Polish. So we have this Goldmanian awkward situation, a kind of hallway handover situation in a way, what we talked about before. So this was kind of, it happened before, you know, very careful with these tools because it says something. And here at least you could express what happened. But in other ways, when you, in other contexts, when you check this and there's no joint repertoire, it causes panic. This is not to say that it is against it. So now they're using this tool in combination with their joint repertoire in French. And the system asks, this is the system, asks questions, and you can clearly see that according to the previous history taken, which you have not seen, the rhythm is much better. This voice is much more relaxed. And she provides much more information than she would do before, because of something in her mother tongue, which is kind of a patient-centered approach, which prompted the patient to provide more information. And that was quite interesting. So the main findings of this, I don't know, it was 5 minutes, because the 15 minutes went so fast, so probably these 5 have gone even further. 1.5. Basically, often they think that it is the language or the culture, and they look through the lenses of the language of the culture, whereas there are just more generic communication issues, as we've seen in the previous presentation or the other presentations. But because they want to kind of, they attribute the problem to communication and culture, they try to repeat questions, often when there's no agenda, okay? When there's a difference in agenda, there's also role conflicts, because you don't know who is who, and you're not explicitating it. 1 minute, yeah, I practiced, but it's Anyway, what is important is that there is, it's very important to be aware that the intensity of a language barrier can vary. At the level, it's actually a complex system at the micro level of a consultation itself. So at the beginning, it can be fine, bonjour, ça va, and then the questions come, since when, how much was the color? And it's not that kind of, you will say, I'm not understanding, like the lady said. Often people don't say, it's face-saving, it's like in academia. Oh, of course I understand. Oh, no, yeah. I know that all there, obviously. You know, it's very similar. And checking, often the clinicians, particularly, they didn't check, have you understood? You would think, you know, you check, but in this particular case, they often didn't, but they were not aware that they were not doing it. So it's a kind of language barrier. The point is that you don't see it as you're speaking. You think they're understanding, nodding, and it's often what is not said. If you ask them, oui, I always interview them just afterwards. You know, it was actually kind of an informal handover. And that there was a big difference in that, on how they had perceived the communication in their clinical takeaway and what has happened really. So that's what actually they were surprised by. And often you don't know who is who, which leads to a lot of problems. And I mean, I thought it's not a title with opening Pandora's box. And it's also James said. The question is, if you're really checking, have you understood? You become responsible for understanding. If you just say, oui, ça va, je pense que le patient a bien compris, you know, it's fine. You don't want to know. And maybe unconsciously or consciously, people don't want to open Pandora's box, because the less you say, the less miscommunication there may be. Well, anyway, just one thing. I know it's not good because you have a new break. I'm looking at you. I think something very important here is, and it's not new, but you can clearly see it, is that the stress of the communication apprehension that we know, you know, the stress clearly plays an enormous role in the quality of communication because of the impact on cognition. Like me, I'm presenting here, I'm a bit stressed, so I've become even more chaotic. It's a normal thing. And actually, this is, and then I'm going to stop. So for the informed consent system, we designed this audio informed consent system. So they would play, this is blah, blah, blah. And I asked them, please imagine that your auntie from Baghdad is here and that she would be here. How would you address her? So hello, this is a research project and blah, blah. But the thing is that they would use my tablets all over, even when I wasn't present, just to click, to give some information to the patient in the mother tongue, and everybody started smiling and the voice was much more relaxed. This means that I think cognitive bandwidth is created for the real work. And I think this won't solve the problem, but being aware of that, and also for that man or people who don't believe in communication, or at least they say they don't, it will help them as well to recognize the human in themselves and see that it's completely normal, that they should become more relaxed. So basically, this integrating it into clinical skills with a clinical picture, clinical skills. We started a new project actually, and I called the chief of DVD. Hey, I've been doing this research. You want to do this? Why? I just explained him, and now we're doing it. Anyway, I'm going to stop. Otherwise, I cannot stop.